Welcome to Medical Specialists Associates educational series on topics in anesthesiology. I'm Christopher Voss, MD, MS, board certified in anesthesiology, critical care medicine, neurocritical care medicine, and pain medicine. Postoperative nausea and vomiting, PONV, remains one of the most common and distressing complications following surgery, with an incidence rate of around 20 to 30% in the general surgical population. In high-risk groups, such as female patients, non-smokers, those with a history of motion sickness or previous PONV, and patients receiving volatile anesthetics or opioids, the incidence can rise to 70 to 80%. PONV management is a priority for anesthesiologists, as it affects patient satisfaction, delays discharge, and can lead to more serious complications, including aspiration, dehydration, and wound dehiscence. This presentation explores current strategies for minimizing PONV, treating it effectively when it occurs, and highlights future innovations in this area. Risk stratification and multimodal prevention. Risk factors for PONV. The first step in effective PONV management is identifying patients at risk using predictive models such as the APFL PONV risk score, which identifies the following key factors. 1. Female gender. 2. History of PONV or motion sickness. 3. Non-smoking status. 4. Use of postoperative opioids. Patients with 2 or more of these risk factors should be considered for prophylactic multimodal antiemetic therapy. Pharmacologic prevention. 1. 5-HT3 antagonists. Ondansetron. Ondansetron and other 5-HT3 antagonists are the cornerstone of PONV prophylaxis due to their efficacy and minimal side effects. They block serotonin receptors in the chemoreceptor trigger zone. Ondansetron is most effective when administered at the end of surgery, typically at a dose of 4 milligrams IV. 2. Corticosteroids, dexamethasone. Dexamethasone, 4 to 8 milligrams IV, is widely used for its long duration of action, administered at induction. It acts on multiple pathways, reducing inflammation, and has antiemetic effects lasting over 24 hours. Combination therapy with 5-HT3 antagonists enhances effectiveness, especially in high-risk patients. 3. NK1 receptor antagonists, aprepitant and fosaprepitant. Aprepitant and fosaprepitant inhibit neurokinin-1 receptors in the chemoreceptor trigger zone, providing long-lasting protection against PONV. Their role is expanding, particularly in high-risk patients or those undergoing long surgeries. Administered orally, 40 milligrams, or IV, 115 milligrams, these agents are especially useful for delayed PONV. 4. Anticholinergics, scopolamine. Scopolamine patches, 1.5 milligrams, can be applied behind the ear the night before surgery. It inhibits muscarinic receptors in the vestibular system and is particularly useful in patients prone to motion sickness. 5. Dopamine antagonists, droperidol, haloperidol. Droperidol, 0.625 to 1.25 milligrams IV, and haloperidol, 0.5 to 2 milligrams IV, are effective for PONV prevention. Droperidol has a black box warning due to its association with QT prolongation, requiring ECG monitoring in at-risk patients. 6. Gabapentinoids. Preoperative administration of gabapentin, 300 to 600 milligrams, may reduce PONV by decreasing the requirement for opioids postoperatively. Its role in PONV is emerging due to its opioid-sparing effects. Non-pharmacologic interventions. 1. Anesthetic technique. Total intravenous anesthesia with propofol significantly reduces the risk of PONV compared to volatile anesthetics. For high-risk patients, TIVA is recommended to eliminate the emetogenic effects of inhalational agents. 2. Minimizing opioids. Opioid-sparing techniques, such as using regional anesthesia, multimodal analgesia, such as NSAIDs, acetaminophen, and adjuncts like ketamine and lidocaine infusions can significantly reduce PONV. 3. Hydration. Adequate perioperative hydration with crystalloid fluids can reduce the incidence of PONV, particularly in long surgeries. Dehydration is a known contributor to postoperative nausea. Treatment of established PONV. For patients who develop PONV despite prophylaxis, it is essential to avoid repeating medications from the same class used in prophylaxis. 1. 5-HT3 antagonists, ondansetron. Ondansetron or granisetron are effective in treating acute PONV, even in patients who receive them prophylactically. If PONV occurs after 6 hours, a repeat dose may be administered. 2. Rescue antiemetics. Medications from different classes such as metoclopramide, dopamine antagonist, dimenhydrinate, H1 antagonist, or prochlorperazine are useful alternatives for treating breakthrough PONV. 3. NK1 receptor antagonists. In severe cases, aprepitant can be administered postoperatively to treat refractory PONV, particularly in patients undergoing long procedures. 4. Acupressure. Acupressure at the P6 Naguan point has been shown to reduce PONV and can be combined with pharmacologic treatments for additive effects. Future advances in PONV management. 1. Serotonin transporter genetics. Research into genetic polymorphisms in serotonin transporters may allow for personalized PONV prevention, tailoring antiemetic therapy based on an individual's genetic profile. 2. Novel NK1 antagonists. New agents, such as rolapitant, which has a half-life of up to 180 hours, are being investigated for their ability to prevent delayed postoperative nausea and vomiting, offering potential benefits over current NK1 antagonists. 3. Transdermal scopolamine formulations. Advances in transdermal drug delivery systems are improving the effectiveness and ease of use of scopolamine, providing more consistent drug levels with fewer side effects. 4. Emerging non-pharmacologic technologies. Electroacupuncture devices and transcutaneous electrical nerve stimulation are under investigation as non-invasive methods to control PONV by modulating neural pathways associated with nausea and vomiting. Conclusion. Managing postoperative nausea and vomiting effectively requires a combination of risk stratification, multimodal prevention, and tailored treatment approaches. Anesthesiologists should utilize evidence-based strategies, combining pharmacologic agents from different classes and considering non-pharmacologic interventions when appropriate. Advances in personalized medicine and new pharmacologic agents on the horizon hold promise for further improving PONV outcomes. To learn more about topics in anesthesiology, please visit us on our website at medspecialists.net and subscribe to our YouTube channel.